What's up, everyone? Today we're talking estrogen because it is, much like all hormones, very underestimated in its role in the body for health and a lot of other things. Specifically, estradiol. There's three types of estrogen. E2 or estradiol is the most potent form of estrogen that's found in men and women, and this is specifically important for women. Post-menopause, after labor, and understanding this through their menstrual cycles so that you can better correlate what the issues might be with mood. Postmenopause is a big one because you're effectively losing 90% of production of estradiol in the body, leading to wrinkles, joint issues, arthritis, potentially autoimmune diseases, thyroid issues, osteoporosis. LDL cholesterol for menopause is a big deal. And that's why it's important to understand that hormones are needed in the body. And when we see menopause reduce 90% of estrogen and other hormones like progesterone and potentially lowering testosterone in women, this is not a good thing. And it's important to understand this in men as well, because in today's cookie cutter clinic world, there's a lot of people doing things incorrectly for TRT, specifically giving aromatase inhibitors that diminish men's estradiol numbers down to single digits, which is not a good thing by any means. But the typical cookie cutter clinic person that doesn't exactly know what they're doing by just throwing everyone who's on TRT on an aromatase inhibitor is doing some damage. So let's get into it. Starting off with how estradiol plays a role in mood. Estradiol has a specific role in creation of monoamine oxidase, which is an enzyme that breaks down serotonin. Serotonin is your mood neurotransmitter, sometimes called quote unquote hormone, but essentially a regulator of mood. So if you decrease your amount of estrogen, then you're going to increase the amount of MAO, which a lot of people now do the methylene blue to get more MAO in it, but you're going to increase the enzyme. An enzyme is just a chemical catalyst that breaks down things that would otherwise take millions of years in the body to happen. But the monoamine oxidase is going to break down serotonin quicker and therefore not allow it to be in the synapses for the brain directly correlated with mood. So essentially, low levels of estrogen are going to let MAO be more prevalent, therefore breaking down serotonin quicker, leading to depressive symptoms. And we see this with different times of cycle. Beginning of ovulation, estradiol significantly increases in order to cascade another litany of hormones to increase the blood flow to the uterus for women in order for ovulation and potentially an implantation of an egg in the uterus. And then, as we see in postpartum depression, you have a significant increase in estrogen and many other hormones during pregnancy, after pregnancy essentially dropping off a cliff, leading to this lack of estrogen, therefore lack of regulation on MAO, leading to a severe breakdown of serotonin and therefore leading to depressive states, potentially, very low mood, very low happiness with things. And this is commonly combated with an SSRI, or a selective serotonin reuptake inhibitor. Essentially, an SSRI is just blocking the ability for serotonin to be taken back up into the brain, therefore allowing for more serotonin to be available. This is not always good because you can see a buildup or serotonin syndrome and a litany of other things. But in any case, oftentimes a blood panel is not done, or estrogen is not even considered in the fact of postpartum depression, which is interesting because the correlation between hormones and estrogen and mood typically is never made. So this would be important to understand baseline for estrogen hormones in order to get out of that depressive state. That would be a pretty invasive fix that's very often overlooked. Alternatively, in men, we always attribute testosterone to being the mood and aggression and moodiness, the roid rage of things. potentially true in super physiological levels of testosterone and other androgens that they're introducing into the body. But for a man that's on a typical testosterone replacement where he's not going up, to 1500 nanogram per deciliter of total testosterone level, oftentimes are with these cookie cutter clinics where these MPs are just kind of gunslinging. They're throwing them on aromatase inhibitors, and aromatase is an enzyme that converts testosterone to estrogen. So if you raise testosterone, you're consequently going to raise estrogen, and therefore they put them on an aromatase inhibitor because they start getting sensitive nipples or moodiness. But the aromatase inhibitor can potentially crash estradiol levels to single digits, therefore leading to moodiness and issues that are directly connected to testosterone instead of the relationship between estrogen, MAO, and serotonin. So something to consider if you are a male on TRT. Aromatase inhibitors aren't necessarily the answer. More often than not, it's adjusting dosages. And one thing that's often not considered is prolactin, because as soon as men on TRT get sensitive nipples, they think, oh my gosh, I'm going to get gyno and I'm going to have moobs. Not necessarily always the case, but your body is when you get on testosterone replacement therapy, your body is essentially figuring out what the heck is going on because it used to make its own and now it's getting out exogenous testosterone. So you have to understand that there's going to be adaptations that need to take place and occur. And a common thing is sensitive nipples, jump on an AI. Oftentimes reduces those symptoms because there's a lot of estrogen receptors in the in breast tissue and in the nipples. So if you increase estrogen, you could increase that sensitivity. But think of estrogen when it comes to gyno. Think of that as the fertilizer, allowing for more nutrients and blood flow to the nipples, and then increasing the likelihood of tissue growth. But then prolactin comes in, and prolactin is the tissue creator. So estrogen kind of feeds it, and then prolactin comes in. So oftentimes prolactin is not even pulled on a blood panel when men have these symptoms, and absolutely should be even before starting TRT, just to understand a baseline level. But again, gunslinging, not necessarily looking at prolactin or even considering it. But before jumping on an aromatase inhibitor, if you're experiencing symptoms, nipple sensitivity and potential symptoms of gynecomastia, absolutely pull prolactin. And then there's potentials you can do to block the excess prolactin rather than get on an aromatase inhibitor, crashing your levels down to zero. So another way it plays a role in the serotonin production is 90% of your serotonin is actually in the gut, and it helps with peristalsis, which is movement of food through the digestive system. So oftentimes women that are going through their cycle have bloating, cramping, obviously cramping coming from another spot too, but this could add to that cramping. The serotonin plays a role in muscle movements in our digestive system. So if you reduce serotonin in the digestive system via reduction of estrogen, then you could potentially see a more challenging time moving and digesting food through the gastrointestinal tract. So it plays a role in this, and specifically to it's a additive to an enzyme that helps create tryptophan, and tryptophan is an essential amino acid. Essential amino acids are amino acids that we can't get made inside the body. We have to get them from a nutritional source. There's 9 of them, and tryptophan is a precursor to 5-HTP, which is a creator of serotonin. So if you have a lack of this amino acid tryptophan in your diet, this could be causal potential of mood. There's a complicated relationship between does serotonin that's in the digestive tract and in the stomach and made through tryptophan the blood brain barrier or not. Some studies say that the brain makes its own serotonin. They're separate things, but the body's more nuanced than just like this is A and this is B. So either way, it's important to understand what we're eating and eat things that are giving us nutritional value. So things to consider too. So post-menopause, when a woman is effectively making 90% less estrogen, bloating and digestive issues are very common. And that connection also is not often made. A big one is wrinkles, collagen production, hair thickness, because collagen is a protein that is going to help with the thickness of nails, hair, and help with supple skin. But estrogen plays a role in the production of hyaluronic acid. Hyaluronic acid is a saccharide, which is a sugar, and has an osmotic gradient for water. So it's hydrophilic, meaning it likes water, and it can hold 1,000 times its weight in water. So sugar pulls water. That's why you see in physique competitions, some people might recommend eating a giant bowl of cereals because all that sugar is going to pull the water from the skin into and make them look leaner, right? Well, if you have a lack of estrogen, therefore a lack of hyaluronic acid, which is a saccharide again, uh, then you will see a reduction in moisture. And hyaluronic acid sits below the skin in the dermis and underneath the sebaceous glands, and sebaceous glands release sebum, which is oil for our skin. So if you have correct amounts of estrogen, the skin is properly hydrated, and therefore the sebaceous glands don't need to release oil or sebum to the skin to moisturize it. Therefore, you have softer, more supple, wrinkle-free skin that isn't as oily. And so the hyaluronic acid is a huge player in synovial fluid in the joints. So it's essentially hydrating the synovial fluid. The hyaluronic acid draws water into the synovial fluid. Synovial fluid holds that in there. And when you reduce estrogen in men and women, so women post-menopause and men on TRT on an aromatase inhibitor, this is a big deal because you talk oftentimes about joint pain. Women see 20% more instances of osteoarthritis post-menopause. It's because this direct correlation with hyaluronic acid in the synovial fluid in the joints. So if your joints are starting to hurt, skin's starting to dry out, wrinkles, like estrogen plays a role in this. It also plays a role in collagen synthesis. Type 1 and type 3 collagen play a role in skin health, bone health, and estrogen has mechanisms of action in that production of collagen 1 and 3. Another big one is osteoporosis. So osteoporosis is very prevalent in postmenopausal women, specifically because estrogen has a role, again, has a role in the recycling of bone cells. So you have osteoclasts and osteoblasts. Osteoclasts, think like consumers. So they're like these little Pac-Men that come along and recycle bone cells. And then the osteoblasts come in and build it back up. So when you don't have an equal playing field of the two, if you're consuming more, recycling more bone cells than you're building back, this is what leads to osteoporosis. So estrogen regulates osteoclasts, helps downregulate them, or at least I shouldn't say downregulate, it helps keep them in check, and then helps the production of osteoblasts, the builders that come back. So when you remove estrogen, you get an overproduction of osteoclasts coming through, munching up bone, and then a reduction in the osteoblast, building it back up. So it's it's not an equal playing field. You're having more consumption of bone than you are of bone building back up, and this is what leads to the loss of bone mineral density, osteoporosis. And it is substantially more prevalent in postmenopausal women over men. And oftentimes you get put on an osteoporosis medication. One of the best things you could do is resistance train, because training puts mechanical tension on your tendons and ligaments from putting stress, good stress, on those muscles. So it pulls on that bone and tells osteoblasts, like, we're having we need to build because we have pressure in here. We need to build back. So it excites those osteoblasts to kick back in and compete with those osteoclasts, even with the lack of estrogen. Pretty substantial numbers, too, of building back bone density in women who resistance train, according to the studies. Osteoporosis medications sometimes like keep up enough, but as far as building the bone minerals back, but compare it to like inflation where it's just like it's rising every year. I mean, we're trying to keep up, but can we? Potentially, but also maybe not. So we see a correlation as well with LDL cholesterol and the argument of is cholesterol is cholesterol the driver of cardiovascular diseases and heart attacks and stuff? Some research says yes, some research says no. Bottom line is post menopause, you see an increase of 15 to 20% of cholesterols, and specifically LDL in hepatocytes, which are liver cells. They have LDL receptors, and estrogen has a correlation between the increase of hepatocyte LDL receptors. What this means is it allows for LDL to be drawn and cleared out of the blood quicker. So when you downregulate these receptors, you have an instance of more LDL cholesterol because there's less receptors to uptake this type of cholesterol, therefore leading to an excess or an increase of LDL cholesterol in the blood. And again, 15 to 20% increases in women post-menopause. And then they saw with hormone replacement therapy that included estradiol, the decrease was like 20 to 30% of LDL cholesterol coming back down. Total cholesterol went up after menopause. Triglycerides went up after menopause. So it plays a role in cholesterol as well, and on heart health it it helps synthesize nitric oxide, which is a gaseous molecule that helps dilate or open up our vessels and helps for the endothelium health, and the endothelial cells are the lining of our vessels, so it increases blood flow and vasodilation via nitric oxide, and that helps for increased angiogenesis, which is vessel formation. So estrogen ignites the nitric oxide in the blood, opens up the vessels, and you see a significant increase of cardiovascular events from premenopause to postmenopausal women. An increased blood flow via vasodilation reduces systolic blood pressure, which is it's not advantageous to have increased instances of high blood pressure, and to increase the nitric oxide helps with the endothelium health. Endothelial health is a direct correlation with atherosclerosis, which is hardening of the vessels. So if you start to damage the endothelium, that's where you start to see more of the plaque buildup and instances of cardiovascular events. And then that's how the LDL cholesterol correlates by getting stuck in the endothelium, and macrophages come in and engulf that damaged substrate. And then you have the potential of it breaking off, a thrombi breaking off, and then it leading to heart attack or stroke. But the increased blood flow is beneficial, and a supple endothelium is going to help prevent downturn effects of oxidation in the endothelium, leading to less instances of potential cardiovascular events. So it would be good in men as well that are again on a TRT aromatase inhibitor, and I keep going back to that because it's oftentimes aromatase inhibitors crush levels down to single digits, which is not good. Alternatively, men that are aging go through what's called andropause, and this is when their Leydig cells in their testicles become less sensitive to luteinizing hormone from the pituitary gland, therefore producing less testosterone. And when you have less testosterone, remember that correlation between testosterone aromatizing into estradiol. When you decrease testosterone, you're going to decrease the levels of estradiol because the aromatase connection between the two. So as men age, their testosterone decreases because of andropause. Therefore, there's less testosterone to aromatize into estrogen. So potentially leading to a lesser excitatory effect for nitric oxide in the blood. All very interesting. Anyways, estradiol has a very complicated connection with thyroid and specifically thyroid hormones. So oftentimes you see a decrease of E2 or estradiol in postmenopausal women and an increase of TSH, which is thyroid stimulating hormone. And this is concurrent with hypothyroidism, meaning like low thyroid. And the reason that is you would think, oh, raising means higher, but it's because the body is compensating and reading that it needs to raise the levels of thyroid stimulating hormone because it's not seeing the response it should be getting from the current levels in the body. Estrogen plays a unique role. It has a correlation in the conversion of T4 to T3, the primary hormones from the thyroid, and T3 is triiodothyronine, which is the more active compound, and T4, which is thyroxine. And so estrogen has a unique place in converting the T4, the less active, into the T3, the more active, and therefore allowing for the body to use the T3, the thyroid hormone. It also plays a role in thyroid binding globulin, which is a fat in the blood that binds up T3 and T4. So you have bound and free T3 and T4. The reason it binds is similar to sex hormone binding globulin, is so that hormones don't just like dissipate instantly. Like it allows for them to have longer clearance, meaning it just lasts longer in the body. So estrogen has a role in regulating this. So if you decrease estrogen, you could increase the binding globulin, therefore locking up more thyroid hormones. So then the body would read that as a decrease in thyroid hormones and then up regulate the amount needed, therefore raising thyroid stimulating hormone. And then, the woman probably gets put on levothyroxine because they have an increase, which is a thyroid medication. So they're on levothyroxine and then an osteoporosis medication. But in essence, you could have looked at those different numbers and see how they correlate, and more likely than not. And then a statin because your LDL cholesterol is up 15 to 20% than it was a few years back. And all has a correlation with estrogen. Potentially other things, obviously, everybody's different, but it plays a role. Very important to consider understanding your hormones and potentially looking at different blood panels. Not necessary, but to disregard estrogen's role in all these things in the body would be less advantageous to you. And men, when you start your TRT journey, if you start a TRT journey, be cautious of who you talk to, because a lot of times nowadays, business is looking to make money and they're going to do the cookie cutter thing and throw you on some testosterone cypionate, 150 milligrams a week, that's in a carrier oil of grapeseed or some sort of other oil that many men see deleterious side effects from, and then they're going to throw you on an aromatase inhibitor like an Estradiol that's going to crush your estrogen levels, potentially, not everybody, and then lead to moodiness and loss of libido, because serotonin has a direct correlation to libido, because often the complaint of not having high levels of serotonin due to SSRIs is you're just numb. Nothing makes you excited, nothing makes you happy, nothing makes you sad, and you can't then, get hard when you need to because nothing's exciting anymore. So if you're crashing your estradiol, therefore leading to an increased breakdown of serotonin, it could be potentially a thing. And that is a very common anecdotal side effect of after jumping on an aromatase inhibitors. Why can't I get hard anymore? Why do I not have libido anymore? In any case, these are all things to consider, and it's important to understand these things. And the hormone information out there is getting much better, which is good. And less people are scared of them, or at least more introduced to them, which is great, because we did a huge disservice comparing pregnant equine urine estrogen that we gave to women in a subset of studies versus bioidentical hormone estrogen and testosterone that we see today. And a 0.8% increase of potential breast cancer in one subset, which is less than one person for 1,000 people. So new information is good, and now even more studies and trials are coming out of the benefits of hormones, and hormones drive many things in our body. Like the endocrine system is extremely undervalued when it comes to the correlation it has with so many other things. So it's important to understand these things. Check out the article I wrote on solutionsToWellness.org Like, subscribe, follow on Instagram, share the video. Thanks.